Hello, my name is Brittany E. Ramo, and I'm a Regis College Family Nurse Practitioner student. Thank you for your time today and watching my presentation for my grant proposal on the study of inpatient diabetes education, reducing hospital readmissions. I currently work as a certified diabetes educator in an outpatient clinic, and I have also been living with type 1 diabetes myself for almost 30 years. So needless to say, this topic is extremely important to me, both professionally and personally. This study is to show the correlation between starting patient education on diabetes earlier in the inpatient setting rather than waiting until uncontrolled diabetes hemoglobin A1C results have set in and other complications and comorbidities of uncontrolled type 2 and type 1 diabetes. This study, like many more, are very crucial to show the need due to the correlation of lack of inpatient diabetes education and patients' overall health status and hospital readmission rates. Currently, there is 34.2 million people diagnosed with diabetes in the United States, and this number continues to grow at an alarming rate. 26.9 million people are diagnosed with diabetes, but 7.3 million people walk around without even knowing that they have this potentially deadly disease. Oftentimes, they are told that they have diabetes when they end up in the hospital, usually secondary to another diagnosis or comorbidity of their uncontrolled blood sugars. Millions of Americans 18 years and older also are walking around with prediabetes, and this is 34.5% of the entire adult United States population. That number is huge. What is uncontrolled diabetes? The American Diabetes Association defines this as a person living with diabetes having a hemoglobin A1C level greater than 7%, and this can lead to complications. Often, conditions leading to hospitalization or certain treatments for other hospital admissions can increase blood sugar levels. This can often trigger or continue the progression of diabetes. In 2016, 16 million adult emergency room visits were found to be secondary to diabetes-related health issues. And in 2017, diabetes was the 7th leading cause of death in the United States. Some complications of diabetes that is uncontrolled are heart disease, blindness, kidney disease, kidney failure, amputations, vascular disease, heart attacks, and strokes, to name a few. The healthcare crisis that the United States is currently presented with is not helped by the increased estimated cost of diagnoses of diabetes and their treatments. About $327 billion is the average cost most recently in 2018 for those living with diabetes as well as hospitals that are treating this condition. According to the NIH, it also shows that hospital admission rates are 2 to 6 times higher in people with diabetes than without, and also they have longer hospital stays compared to those living without diabetes. The purpose of the study is to show that there's a positive correlation in early and aggressive education and management of diabetes by trained staff at the inpatient level, and this will lead to a decrease in hospital readmissions secondary to exacerbated complications of uncontrolled diabetes. The aims of the study are to identify patient admission diagnoses that are complications of uncontrolled diabetes, to identify current doctors, physician assistants, nurse practitioners, and nurses that are working at the inpatient level and their knowledge and comfort of managing and educating patients with uncontrolled diabetes, and to compare admission rates of admission diagnoses that are complications of uncontrolled diabetes to other facilities with an inpatient presence or program. I am hoping that the results of this study will show the need and increase the number of inpatient diabetes management education programs and resources to patients while they are at an inpatient level. I also hope that this will improve diabetes cares for patients upon discharge, reduce hospital admissions due to health complications caused by uncontrolled diabetes, and also decrease healthcare costs of diabetes for patients and hospitals. About 17% of inpatient people have diabetes, and about 36% of these patients are on insulin therapy of some kind while in the hospital. Greater than 90% of hospital admissions have diabetes as a secondary diagnosis during their admission stay, and 38% of inpatient medical records show at least one diabetes medication error within a week of a patient's hospitalization. Trainee doctors specifically had a knowledge deficit in diabetes management while at the inpatient level, and 30% of those discharged patients that were in the hospital that had diabetes will have a readmission to the hospital at least 2 more times within a 12-month period. Upon review of literature, many common themes were found from adding education on diabetes at the inpatient level. Nurses who completed a training program to advance their knowledge on this topic increased their knowledge drastically from 66.3% almost to 85%. Floor managers also noted improvement in patient health outcomes. Having an inpatient diabetes education program for prescribers and providing staff also improved many things. There was reported improvement in patient care, reduction in insulin and non-insulin related medication errors, and also a reduction in diabetic ketoacidosis or DKA occurrences while in the hospital. It was also found that utilization of diabetes self-management education on the outpatient level was not utilized very often. Only about 7% of commercially insured patients and less than 2% of Medicare insured patients actually used this benefit within a year of being diagnosed with diabetes. This again shows that starting education at the inpatient level and also providing continuity of care upon discharge will help patient outcomes. Continued education for nursing staff also will help address deficits in knowledge on insulin, hypoglycemia management, glucose monitoring, and injection techniques, all of which are important and crucial elements for survival for patients newly diagnosed with diabetes or who have been living with the condition for a very long time. Diabetes specialty care teams showed a reduction rate for 30-day hospital readmissions, decreased of cost while inpatient, higher incidence of hospital discharge, follow-up for diabetes management in the outpatient setting, and shorter hospitalization stays for those patients. Doctors and advanced practitioners can also bill for inpatient consults, which can also improve hospital revenue for the inpatient. Inpatient certified diabetes educator presence also showed a reduction in hospital 30-day readmission rates by 5%, again, helping to reduce the overall healthcare costs. Educating patients on signs and symptoms to monitor for at home also reduced hospital readmission rates. Higher incidences of self-sufficiency for patients also led to improved adherence to care plans and medications. Improvement in patient confidence was also seen when proper inpatient education and management was taught to patients prior to discharge. The American Association of Clinical Endocrinologists and the American Diabetes Association all recommend that diabetes educators be utilized at the inpatient level to address specific patient needs that live with diabetes. It also recommends that they be a part of the care team while admitted to the hospital. Unfortunately, only 24% of diabetes educators work within a hospital setting. These facts help to reinforce that there is a strong need for further research and investigation of the benefits of inpatient diabetes self-management education, and that is what I'm hoping that this study will be able to help with. As was previously mentioned, there is still need for further research for the long-term evaluation of patient outcomes with using inpatient diabetes education. There unfortunately is a minimum reimbursement for diabetes self-management education at the inpatient setting, which raises the issue of cost for hospitals to be able to staff these vital staff members. The more that this topic is researched and shown the positive correlation in early diabetes inpatient education and improved patient outcomes, the more we will be able to make a change in our law and healthcare coverage to be able to reimburse for such services. The study's theoretical framework is around Gene Watson's theory, which focuses more on nursing and the impact that nurses have on a patient's environment to help promote their health. It also focuses on people being deserving of care, respect, and understanding, assistance, and nurture. This also influences the nursing process of assessment, plan, intervention, and evaluation. Earlier diabetes education helps to focus on a holistic care for patients, which is a crucial element of Gene Watson's theory. Nurses are a key element in a patient's environment to deliver care and promote health, which again is strengthening the need for them to have further education in diabetes management so that they can properly educate their patients on their disease. Within my study, I hypothesized that hospitals with an inpatient presence of trained staff to conduct such diabetes management and education for patients will have lower readmission rates of diagnoses secondary to complications of uncontrolled diabetes. The hospitals with such a presence of trained staff to conduct this type of education and management will also have improved patient outcomes through reduced occurrences of complications and comorbidities from uncontrolled diabetes. The study will recruit participants through a stratified random sampling focused on age and diagnoses. The age will be 18 years and older for participants, and their past medical history will include diabetes mellitus as well as complications of diabetes, as can be seen here. All patients discharged from the hospital within a 12-month period will receive a mailed letter to voluntarily complete an online or paper questionnaire for this research study. Criteria for patients is as seen here. They must be discharged within 3 to 12 months. The hospitalization at the time was for diabetes or a diabetes-related comorbidity, be 18 years of age or older, had a follow-up A1C since admission. The questionnaire will be anonymous, and people will not be eligible for the study if they do not have a diagnosis of diabetes mellitus, if they live in a medical facility or long-term care facility, and do not make medical care decisions for themselves or have an active healthcare proxy. Sampling will be purposeful. This proposed sample size for the study will be 50 participants who were patients, and the data will be collected until saturation is achieved. The setting of the questionnaire will be natural, with participants completing it on paper or online while at home. IRN approval will be obtained, and I will submit an application and proposal to the Regis College IRB first, followed by the institution where the study will take place. Informed consent must be signed and expedited review will be requested. There is minimal risk to subjects. No intervention is being done towards participants. It is possible that there is a psychological risk to some participants recalling a prior hospital admission if they had a negative experience during that time. An anonymous questionnaire will be used. Identified data will be maintained in a locked file, which will remain in a locked office of this researcher. There are no foreseen ethical issues, and the results will remain anonymous. All participants will receive full clarification of the purpose of study, the research process, and the research results in order to ensure that participants can make an informed consent to participate in this study. The questionnaire will evaluate patients who received diabetes education and those who did not in the hospital, and how their diabetes management and control is as a result. Questionnaire results will be giving numerical value. A trend and correlation will be associated between diabetes education and management received in the hospital and how patients managed their diabetes upon discharge and at home after hospitalization. The PSS scale will also be used to measure a patient's level of stress upon discharge from the hospital in regards to managing their diabetes at home. It is suspected that lack of education to a patient while in the hospital will increase stress once they are discharged, and this will also result in poor diabetes care and control. This, of course, will lead to an increase in incidence of complications and more frequent hospital admissions for that patient. Diabetes education has been directly correlated to improved glycemic control. This will also improve patient outcomes and reduce comorbidities and complications from diabetes. The proposed change is that the inpatient diabetes education program will be established in the hospital and used while a patient is admitted. The sooner education begins, the sooner improved patient outcomes that can result. Staff who continue to have education on diabetes management and education will also help improve patient outcomes and prevent complications of diabetes. This will lower admission rates for patients due to complications secondary to uncontrolled diabetes. This will also help save money for patients, hospitals, and insurance companies. Please see my references here. If you have any questions, I can be available after the presentation to go over those. Thank you all very much for your time.